Thank you. Good afternoon. Whoop. Is it working?
Yeah, that's all.
Okay, good afternoon, everyone. Sorry that we are running a little bit late. Did you have a sign-in sheet? Okay. Okay, there is a sign-in sheet. Although I will tell you that we're not going to take, we are down to the wire, and we have important bills to get out. Not that input is not important from our citizens, but we probably will, if there are a lot, have to limit the number of minutes that you can speak. And so I just wanted to let everybody know that so they wouldn't think we're picking on them. And I will ask you that if somebody has already said something, that you not, go over and over again on the same thing, if at all possible, please. If we take and get to that if you're speaking on an issue. Okay, and we're going to start to the committee. Good afternoon, everybody. Thank you for coming and showing up. We're going to start with Representative Deborah Silcox bill, HB 719. And I personally would like to thank Representative Silcox and everybody that has worked on the bill. We have learned a lot since the early 1980s when many of our HIV laws were passed. And we now scientifically have a great larger deal of information and know a lot more about what really happens and how you can become infected at all. And it is time for us to remove part of the stigma that keeps people that are HIV positive from getting treatment or even to go to be identified, which then puts the rest of our population at risk for further infections. So Deborah, thank you very much for carrying this bill, and thank you to everyone that worked on the bill with you. I know it's been a lengthy process. I've been in on one or two of those sessions, and I think we've come up with a good bill. So you have the floor.
Thank you, Madam Chair. We are looking at LC 33828-1S. If you have that in your packet, does everybody have that correct sub?
Everybody
Right.
okay?
Great. Then I'll just walk briefly through the bill. As Madam Chair mentioned, this bill overall really is just an attempt to update our laws from the 1980s in terms of the definition of HIV and treating those people with HIV evenly with respect to crimes as well under the law. Under Section 1, just on the first page, just clarifies an HIV test, which sounds like a simple thing. Under Section 2, we're amending the criminal code to accomplish several things. Turning to the second page on line 38, this requires the person living with HIV that they have to have intent to harm another person, to transmit HIV, to be charged. Lines 42 through 45 clarify that a person who is HIV positive and is the victim of a sexual assault cannot be charged for a crime for not disclosing his or her status to his or her attacker. Lines going to the third page, lines 66 through 67, they change the criminal charge for non-disclosure of status from a felony to a misdemeanor, and require proof based on current scientifically supported levels of risk that the conduct had a significant risk of transmitting the disease. And probably most importantly, there at line 68, this deletion of Section D is important because this part of the statute brings us in line with the legislation passed in 2016 called Back the Badge, and it ensures that a battery against a corrections or any law enforcement officer is a battery with no additional requirements of proof of status as to the offender. So anybody that has this type of behavior against a police officer, whether they have HIV or not, would be subject to a felony for obstruction of justice. Section 3 The changes in this section really are to follow up on our the fact that we passed the needle exchange legislation last year, and so this amends at lines 99 and 100 on page 4, just to say that this doesn't apply. This code section shall not apply to an unusable amount of a controlled substance in a hypodermic needle or syringe. Section 5, 6, and 7 do the same thing. They just clarify that those sections don't apply as well to a hypodermic needle or syringe. And so this cleans up all those other sections through the end of the bill. I'd be glad to take any questions that the committee has.
Questions from the committee? Need a minute to think about it? Oh, okay. There we go. Representative Dempsey.
I don't have a question, but when you're ready, I think we should vote
Okay.
to do pass.
Okay. I'll take that when we're ready. Okay, questions?
Madam Chair,
Yeah.
when we're ready, I would like to second the chair lady's motion.
Okay. Representative Barr.
Thank you, ma'am. For a non-attorney, on line 38, is there a definition legally to intent with act with intent? Intent, does that have? Can you help me understand that a little bit?
Criminal law basically says that in order to be charged with a crime, that you have to have a mens rea, which is that you have to have intent plus the action equals the crime. So that's just an element of the crime.
Thank you.
Okay. Sorry. Michael went to get the sign-up sheet. Okay. Okay, Ms. Martinez, are you speaking against the bill?
No, I'm just providing some context and justification.
Well, you did that once before, and you have a very moving story.
I have an update. Nobody has heard this.
Okay, well, but you confused everybody last time.
Well, people have been primed now, so I promise it's fairly straightforward and brief.
Okay, couple minutes. Yeah, I mean, we don't get us to where we don't.
No, I just, for other people who may not know the harms of the current law, because public opinion is also
Okay,
important to
all right.
help
Well,
sway.
and you have certainly a very moving and telling story. I didn't mean to, in any way, demean that, because it was. But there were some people that got confused, and this is an important bill.
That was
Pass.
then, we're here today.
Okay, go.
So my name is Nina Martinez. I'm here as the first person in the United States living with HIV to donate a kidney to another person living with HIV, and third globally, which you can, appreciate requires a refreshed knowledge of current HIV understanding. So I really thank you so much for having this bill. A lot of people, when you first tell them, somebody should tell me their HIV positive status. Here's the thing about disclosure. The disclosure law as it stands is ineffective, first of all, because new HIV transmissions happen between two people where both of them don't know that one of them is HIV positive. That's the first thing. And if the law, as intended, was effective at preventing HIV transmissions, then why is it that nearly 4 decades later, Georgia remains an epicenter of HIV in America? Secondly, the current law is dangerous. People assume that it's safe to disclose when people have been harmed or even killed for disclosing. So just because somebody doesn't want to disclose their HIV positive status may not be it's not equivalent to criminal intent to harm. And finally, this is why, is that disclosure is unnecessary for HIV prevention. Each party in a consenting sexual act has the means to prevent acquisition or transmission of HIV, no matter what is or is not said between them. We know what HIV prevention is. HIV prevention is pre-exposure prophylaxis. HIV prevention is condoms. HIV prevention is voluntary couples counseling and testing. HIV prevention is also abstaining from sex if, acquiring HIV is a big risk for you and you're concerned about it. So just on those 3 points, the current law is ineffective, It's dangerous for people, and not only for the reasons that you described for public health, but also personally, and it's unnecessary. Thank you.
Thank you very much for coming to talk to us again. And you're right, that was an update. Thank you. Just a second. I do want to add to that. We did have some confusion last year, 2 years ago, in a bill that started to move. And I see Sheriff Norris here. And if there's any law enforcement, I'd like to get something, or first responders, Dexter. We now have a medication if someone is exposed through blood and real means of being exposed to HIV. There is now a medication, if started within 72 hours, can prevent the person becoming HIV positive. And there was a misconception and a bill put in that wanted people, if somebody would not disclose whether they were HIV positive or not, and a law enforcement officer in that case had been exposed, that they would go to court and had up to 30 days to get an answer. Well, 30 days is too late for first responders and our police and our firemen and people who might be, or anyone who's exposed. What you need to know, if you think there's a serious risk, I would go to the emergency room and let one of the doctors help me decide. But the other thing, if I really had a real true risk of it, but the other thing is to start the medication within 72 hours. And the sooner that you start it, the better, and the less likely you will develop it. So that is my public announcement for the day. I wish we could make that clear across our state, because we do care and do want to protect our law enforcement, our sheriffs, our first responders, and all, and they and their people that write their protocols and all need to make sure they know the right way to handle this. Okay, Representative Sharper, I'm sorry, don't.
Good. But, thank you, Shirley, and I thank the young lady and everybody that presented. The biggest thing that I can say about this is disclosure is very, very important. Me being in the medical field for 30 years, one of the most refreshing things I received is when I had a patient, he was a male gentleman, and being that we first contact, getting ready to, do some blood work on him, do an IV, and the first thing he said to me, and he's actually, a veteran and everything, he stopped, he said, "Hey, look, before you stick me with this needle, I just want to let you know that I am HIV positive." And, I was already gloved up, but him telling me that, it made everything better. And to this day, I think it was 10 years ago, we have been very close friends. He does a lot in our community. And it's one of the best feelings I had, but it brought us closer because I respected him telling me. So therefore, and I didn't turn around and treat him any different, but him just disclosing that made a big difference. So disclosure is a key factor. So I thank you for bringing this, and I think we'll be okay. Good
Thank you, Representative Sharper. Representative Dempsey, you are recognized for a motion.
Yes, I move do pass.
Thank you. We have a do pass,
Second.
and I have a second from Representative Drenner. Is there any further discussion from anyone? No? Then we have a do pass on the substitute to House Bill 719. That's LC 3382881S. Everyone in favor say aye. Anyone opposed say no. The ayes have it. Thank you, Representative Silcox.
Thank you, Madam Chair.
All right.
I hope you'll excuse
Okay.
me. Thank you.
Okay. Representative Gaines could not be with us this afternoon. There is something very special going on in Athens at the University of Georgia. They are naming one of their buildings after the first African American graduate from the university system. And so Representative Gaines represents that area and asked me if I would present his bill. So I may need a little help. You want to come up to the mic in case I need it? And I understand we have a doctor of podiatry. here. You want to introduce yourself and the doctor?
Madam Chair, I'm Scott Maxwell, representing the Georgia Podiatric Medical Association, and with us today is Dr. Adrian Ross, who is a podiatrist.
So thank you for joining us, Dr. Ross. Now, Representative Gaines gave me 3 pages, and I don't know who wrote this, but it's a real rah for podiatrist. And I don't think we have to go over through the whole thing. I have had surgery on both my feet. I can testify that good podiatrists do a good job, and I'm glad to have them. But it is my understanding that the bill addresses the fact that since diabetes is so prevalent in our state, and one of the really complications with diabetes tends to be neuropathy and then problems with their feet. And we have not been able to have family practitioners, MDs, practice together with podiatrists in the same facility so that patients would not have to, wait for an appointment, go across town or to another county. They could actually be in the same facility and be seen in a more timely manner. Is that correct? And that's the purpose of the bill.
Wonderfully said.
Thank you. And so the other major difference is there was some out-of-date information that was on line 63 through 66. And it was to do with the medical board and the podiatry board and examiners, and they had never done what was in the bill. And then it has added also on 80 and 82 and lines 89 and 97 criminal background checks on a national basis for doctors of podiatry. Have I hit the highlights of the bill?
Perfect.
Are there any questions? And I'm going to turn the questions over to y'all. So are there questions from the committee? Wow. My bill's up next. Oops, and I think everybody's going to be disagreeable when it comes up. Aren't you right, John? I think that's the way we like it to be. Okay, who we got? Oh, Representative Hutchinson.
Thank you, Madam Chair. I just have one question. How accurate is that show, My Feet Are Killing Me? I love it, and I just want to make sure that I'm not living in a false reality.
So ironically, one of the physicians, I can't say who, I actually reviewed his contract before he was going out for a job. And
Well, there's only one guy, so.
yeah, I know. So I reviewed it as touche, but yes, quite accurate.
Okay, good.
Okay, here we go. Oh, Representative Henson.
No, I was just going to say at the proper time, I'd like to make a motion.
Okay. And Representative Hogan.
Second.
Okay. Well, it's your good day for both of you. I will add that with the podiatry, I'm probably the only person that has ever bent a pin, not on the outside, but up inside my toe, straight like this and that. The podiatrist asked if he could keep it so he could frame it. It was interesting. And I will have to tell you that toe did not heal right because of me, not because of the podiatrist. And I will tell the committee that they wanted to cut off feet, and I wouldn't let them. Podiatrists can already cut off toes and part of the foot, but I just thought it got a little more complicated when you start to cut off feet at the ankles and so forth, and I am the one person who said, no, I thought we better wait on that. So that was also in the notes I'm supposed to admit to, is that I'm the one who stopped that for you, and being able to have that in the bill. The Medical Association probably has a representative here. You worked with them. Can you give it the thumbs up? That's all I need. There we go. And it's really nice when the two different areas in the medical field can work together, so I appreciate that. Okay, Representative Henson, you're recognized for a motion.
Thank you, Madam Chair. I would like to move that we pass substitute to HB 932. It's LC 338290S.
That's the correct piece of legislation. And Representative Hogan?
Second.
Okay, so I have a motion and a second. Is there any more discussion from members of the committee? Is there anybody burning to talk about this one? No. Okay. Okay. Everyone in the favor of the passage of the substitute to House Bill 932, LC 338290S, say aye. Aye. And everyone opposed? No. The ayes have it. Thank you very much.
Thank you, Madam Chair and committee.
Okay, John, you ready to go sit in the hot seat? Well, yep, we'll go down. And I would like for, oh, sorry. Wait. Katie, sorry, I missed you. No. Go ahead. You're quicker. Okay, so we are going to be taking up House Bill 578. This is a bill that passed out of our committee last year, made it to rules. Right, Katie?
Well, no, it didn't. We introduced it sort of at the end of the year, and then there were some compliance measures with the federal government, so we needed to wait. We just got it kind of in the queue and ready to tackle this year.
So ready to go. Okay, you're ready, and we're ready for you.
Okay, so let's make sure that everybody does have the right bill in front of them. It's LC 338292S.
Right.
So it's truly, totally a compliance measure. Legislatively, this is authorizing the Department of Human Services and its contractors to receive conviction data on volunteer students and interns utilized by the department and its contractors. As you can imagine, that's quite important. There are some very specific, the language changes in here are very, very specific. The consequences to not passing this, which are very important, are that the department will not be able to fully vet through fingerprint-based background checks everyone that has access to DHS clients' confidential information, the information systems, and other information that is confidential or protected in nature or required by law, because current statute limits the types of employees we can conduct fingerprint background checks on. DHS has the authority currently, today, to conduct fingerprint-based background checks on volunteers through the National Child Protection Act, Volunteers for Children Act. However, use of this federal statute requires additional details be gathered and maintained, such as if the person has any prior conviction data before they are fingerprinted. To alleviate this requirement and eliminate the probability of having a Federal Bureau of Investigation audit finding because of noncompliance with all requirements, it is so important that we do it, and we do this exactly like it is, like an issue with the Georgia Vocational Rehabilitation Agency during their 2017 FBI audit. The FBI recommends amending state statute where possible rather than using the federal statute. It is important that the language that has already been vetted and approved by the FBI remain exactly the same through the passage of this legislation. Once passed, it will go back to the FBI for a final approval. If there are any changes to the language that was previously approved, they could elect to not approve the amended statute, which would then jeopardize our ability to conduct any background checks for employees, any, or contractors, to include those that the department is currently, even today, authorized to fingerprint. So it's very specific. It's a compliance measure just to bring us in line with what we need to do with the federal government as well.
Okay. Questions from the committee? Representative Hutchinson.
Thank you, Madam Chair. Okay, so the fingerprint system that they have now is you get fingerprinted, and let's say you're a contractor, you get a letter that says you either can or can't. Does this make it so that you get specific information, like they were arrested on this date, that date?
No.
Is that what this does?
Is
The
this
information is disclosed to the person that requested the background check. And I have our staff attorney here that can address that more specifically if you'd like.
It's just that the issue of fingerprints have come up.
It doesn't allow
Yeah.
the
Go ahead.
contractor to receive the record information. That can only be maintained within DHS. We will still only give that suitability determination. It only allows us to add these classes under our state statute.
Right. Let me see if I can make that. I mean, is it the same one that we're using across the state?
Yes.
Okay. The federal government is very, very stingy
Yes.
with letting anyone use anything from their system. And as you know, we are starting to background check people who work in nursing homes and with elder in any way. And this is a simplification. I mean, the person does the fingerprint check, and the department and all, they have decided on certain crimes that would not allow a person to be eligible to work with elderly people or in the children or whatever. And so what happens, that goes into the federal system, and they basically say, they either sort of give it a green light or a red light. Basically, I mean, it's a simplification of it. And whatever problem that was is not disclosed. It just says no to that. Now, there is an appeals process.
There is on the residential licensing side that's authorized, but on the standard contractor side, the department makes the determination of eligibility based on our policy.
Okay, but there's an appeals process if there's been a mistake.
Yes, exactly,
Oh.
that we're required to do. So if there's an issue with, we have to have them, if there's a disposition missing, or if we have to provide them time to either correct or challenge the record before we make a final determination, which that's all built into our process.
And since this is for DHS, would this do anything to kind of localize the fingerprints if you're doing DHS, like DFACS, DJJ, DBHDD? That does nothing for that.
It does not, because the federal government does not recognize us as what they call related agencies, because we provide different services. So the FBI would have to recognize that as a related agency in order for us to share those backgrounds across agencies. So
Okay.
So they're, like I said, they're very stingy in how they will let the big system be used. And I know that it took the department in trying to get people in nursing homes and all, it took months of negotiation to come up, and I'm sure it was the same for your department to do that, and what they would let people know. So, further questions? Okay, and it's up to the committee? Pardon? Okay, I have a motion to do pass from Representative Lott. No, okay, I've got several seconds. Any other discussion from members of the committee? Hearing none, everyone in the favor of the passage of, if I got the right one, which bill is it? Hold on. We have so many today. Which bill is it, Katie?
Okay, it
Okay,
is
578, 578.
LC 33829 2S
Yes.
for HB
To
578.
the substitute. Everyone in favor, say aye. Everyone opposed, no. Okay, the ayes have it.
Thank you.
Okay, before we go on to the much-awaited nursing, assisted living home bill, I do want to take this opportunity to thank the Speaker, the Lieutenant Governor and his staff, and the Governor's office, and the department, and Representative LaHood, who's helped me work on this, and Representative Petrie, and the seniors, and lots of individuals that have come forward after the AJC's series of articles. I don't normally I don't always agree with the AJC, but I think both of the reporters that are here, I just want to say to you, guys, hold up your hand, you're here. I know you hate to be recognized, those hands went up like this. I personally want to thank you for the series. As legislators, we go about our lives, and we don't know what happens across our state in great detail. And it took you calling me before you called me. I had just about a week before a pharmacist that I know personally whose wife had early onset dementia call me to talk about the care she was getting in a so-called memory care center, where he watched other patients, he would go at meal times, and he watched the staff come in and put a tray down in front of the other patients that had forgotten how to eat, and in a little while come pick up those trays again without offering to help the people eat. And then the article started. So this is one time I am very appreciative of the work that y'all have done on this issue. And to everybody that has had input on working on this bill. And that especially goes for the department also, that was in my office from till 1 until 2 o'clock, and that is why I was about 5 minutes late getting here. So if Joe can come up, and they've been great too. Joe, are you here from the department? And let's go join him, and you can take over, and we'll go through this, okay? And I'll come back when we start having so people testify.
Sure.
What you want, Jesse? You want
Thank you, Madam Chair, for your work on this. I'm going to call out the LC number and make sure we're all handed out the right one. It's still warm. House Bill 987, LC 338301S. Everybody can.
Thank you, Mr. Chairman. If it's all right with you, I would like for Joe to, go through the step by step. We do have some amendments that we want to make as an overall amendment, and we can answer any questions. But first, I'll let him go through and do an overall review of what's in the bill.
Thank you.
Thank you. My name is Joe Hood. I'm the Chief Compliance and Technology Officer for the Department of Community Health. And so overall, this bill addresses changes in the Health Facility Regulation Division's licensure process as it relates to assisted living communities, personal care homes, and the creation of a new certificate program for a memory care center that would potentially be a possibility for application in a provider's licensure of one of those facilities. And then we have some differences on the sizing of those facilities that I'll address as we go through. In the very beginning, if I may, I'll start with Section 1 on lines 22 and line 50. What we're doing here is, in general, providing the ability for the department to create a certificate underneath the licensures that I just mentioned of assisted living and personal care homes. Prior to this, there has not been a certificate program specifically for a licensure, to my understanding, so it's just adding that provision generally to that section. The next section, which is starting on line 54, talks about an expedited waiver process. And the department has a concern here, and we'll address that in amendment, but basically this is in conflict with the Administrative Procedures Act and the timeframes that are outlined there, so we don't believe that we're going to be able to accomplish this as outlined. As we move to Section 3, this is an increase to fines. So I want to be very specific here because this has differences for different types of facilities. The first one that so there are two different basic things we're doing here. We're increasing fines across all licensure types, and then specifically we're addressing a new fine that's specific to long-term care facilities, which are personal care homes, assisted living, and nursing homes, if we're doing a state fine, which is rare. So starting with line 77, this doubles the authorization of the department's daily fine from $1,000 a day to $2,000 per day for all facility types that the department licenses. So that's not just these that we're talking about, because this is in the general statute. It applies to all healthcare facility types where we would issue a fine. The department has a matrix which we utilize when we go out and cite a violation depending upon the facility type. And what this effectively does is the department anticipates it will double each part of that fine that is in that matrix, with the maximum fine reaching that $2,000 per day that would be in place. Moving to the next portion of this, there is the, on line 79, there is a maximum fine presently of $25,000. That is increased to $40,000. So typically how that would occur, if you had a daily fine, for example, of $2,000, you would go up to 20 days. If you went to your 21st day, and just for ease of math, that would put you over $40,000. It would be capped at $40,000 for that fine. So that would be the cap for that, where presently the total cap is $25,000. Moving next to beginning on line 81, this is a new mandatory fine. This mandatory fine of $5,000 is only applicable to personal care homes, assisted living communities, intermediate care homes, or nursing homes if it's state-cited. Traditionally, for awareness, most nursing homes, the federal fine is going to be higher and more severe, and that's how that's going to be pursued. So for operational aspects, we're really only talking about personal care homes, assisted living, and intermediate care homes. In the instance that a death or serious physical injury occurs to a resident where it can be shown that the cause is a violation of rule, law, or regulation of the facility, that would incur a mandatory $5,000 fine. So this would only be for cause of something that has actually occurred. The potential for occurrence, which would probably be cited if we were to go out and something has occurred, would be under the regular fine structure. It's only going to be an event that has actually occurred, and you can show death or serious physical injury. Starting on line 96, there is a provision that's added here to allow the department to deny a license in the event that someone is trying to avert fines by transferring ownership of their license. So for example, if there's a facility and we can prove that they're transferring to a relative or not an arm's length party to avoid licensure, we can deny that new licensure on that basis. Section 4, beginning on line 101, this provision adds personal care homes and assisted living to the statute that already exists for nursing home facilities to give notice to residencies of deficiencies and associated plan of correction. This is already an administrative rule. We recently passed and revised the administrative rule to say it's prominently placed on the website of those who maintain websites, but this is just putting that specifically in statute to mirror that administrative rule guidance, which is more specific. Section 5, this is applying only to personal care homes of 25 or more. We're adding requirements for staffing starting on line 153. This requires each direct care staff to have initial and annual training to demonstrate knowledge of understanding of the care of the elderly, to make sure that there's training of that direct care staff and they know how to treat and understand how the elderly are going to react and so forth. The second requirement here is to maintain a specific on-staff staffing ratio of 1 to 15 in waking hours and 1 to 20 in non-waking hours, provided that such ratio is adequate to meet the needs of the residents. And this provision is repeated for assisted living and in the memory care unit with a ratio, but I want you to pay specific attention to adequate to meet the needs of the residents. The department utilizes this in administrative rule structure now and will continue to do so if this is passed. That is the standard that is going to be emphasized. So regardless of the ratio, if there's a complaint and the residents' needs are not met, there's going to be a focus on adequate to meet the needs of the residents, not so much on a specific ratio. The next is upon application, facilities for personal care homes of 25 or more must demonstrate their financial ability through an affidavit from a CPA to have a going concern of the entity for 2 years. The facility must also provide a 60-day notice of any impending bankruptcy and a 14-day notice of any impending change of ownership. This is to provide residents who may feel that their needs would not be met if the entity is going bankrupt, or if there's going to be a change of ownership and they think services may change, an opportunity to adequately move or address those needs that may occur due to that bankruptcy or a change in ownership. The next is a provision for certified medication aids so they can be minimally available in memory care or elsewhere in the facility. So as I get to that in a moment, you'll see in memory care that we call for the use of certified medication aids, and presently in personal care homes, those were not authorized. So this adds that ability so that we can have those in memory care units, and they can also be used throughout the facility when they're not working in the memory care unit. Moving to Section 6, this is assisted living. Throughout here, I'm not going to go through the particular lines, but everything that I just referenced in personal care homes is replicated in staffing for assisted living. And then in addition to that, on line 285, there's a new provision of a mandatory minimum for limited nursing services to provide assessments of residents' physical, mental, and emotional status to determine the appropriate level of care and allow for intermediate nursing care in the scope of practice that can be completed within 7 days to take full utility of the employed nurse. The main point of this is to have nursing services on staff in these facilities, in these assisted living facilities and in memory care units, so they can adequately assess the patient's needs to see if they need to go to a different level of care. But in the discussion on this, there was, well, if we're going to have a nurse there, we should have the availability from the facility to use their full scope of practice on a limited basis, and that's what was arrived at, is the 7 days on an intermittent use. There is still language in the statute that states that the facility cannot accept someone who requires continuous nurse care upon entrance. So that is not the intent. The intent are small things. The examples that I was given when it was discussed was if you're removing stitches or cat
Maybe the podiatrist.
or a podiatrist.
And then change the dressing one time.
Right, small things that would be one time or within 7 days. It's not meant to be anything that is continuous. The next item is it provides for at least 2 on-site direct care staff at all times. Next, moving to Section 7, on line 337, there is a provision for the inclusion of limited nursing services and notating the allowability of nursing services in this section, but while still maintaining the distinction of services between personal care homes, assisted living, and nursing homes. So basically, we're still maintaining that a personal care home is limited in what it can respond to and the residents that it should take care of, and then a little bit higher acuity for assisted living. And then, of course, skilled nursing means you need assistance with daily living activities and have nursing needs. So we needed an exception here if we're going to provide for limited nursing services, and that's the simple notation. Next, moving to Section 8, is the authorization of the department to create a certificate program for a memory care center. So I referenced this in the very beginning, and this is the detail of the certificate program that would be created. We currently provide for similar activities on administrative rule, but this would place them in statute and give them distinction and guardrails for how they would be administered. So the memory care center, starting on line 390, is described with minimum staffing requirements. But I guess before I get to that, just as a reminder, what we're talking about here is a facility would already have a license to operate an assisted living community or a personal care home before applying for a memory care certificate. So that's the whole basis of why we want just a certificate, because we already have application guidance that you have to have in place to operate one of those facility types, and this certificate would just concentrate on these items that I'm about to go over. So starting on line 390, in order to obtain a certificate to operate a memory care center, the requirements would be that you would have dementia-trained staff of 1 to 12 residents at all times, and provided, again, that ratio is sufficient to meet the needs of the residents. So if there's higher acuity or higher need patients within that 12, then the staff would have to be at a greater ratio to address that as dictated by the residents they serve. So I just need to emphasize that's a minimum and not what you would strive to necessarily. The next is that you would have 2 direct care staff persons at all times. you would have one registered nurse or LPN, licensed practical nurse for limited hours depending upon the number of residents. And then starting on line 417, I wasn't going to go through all of these, but we basically adopted our administrative rules and incorporated the requirements for the facility related to a memory care center and the training requirements for dementia that are outlined there in great detail for the staffing that would be part of the requirement for a memory care center. Moving lastly to Section 9, and starting on line 464, this provision is providing for the licensure of administrators of assisted living communities of 25 or more residents and 25 or more residents' personal care homes. So what we're trying to do here is there is currently a nursing administrators board operating at the Secretary of State's office, and this proposal is to add add training requirements and licensure for an administrator who would operate an assisted living community or a personal care home that is 25 residents or more. So the provision is that we would make changes to the board to add representation of those facility types and to reduce the board from 13 to 9 so that you could have better communication and activity of the board members, but also to have representation throughout. But mainly our purpose is to make sure that we license administrators for these larger facilities in a similar manner as they're done at a nursing home. Although their certificate would be adopted by the board, it would not necessarily and probably would not be the same as what a nursing home administrator is because their residents don't require nursing services. So we would expect that it would be other educational programs that would address that certificate need as determined by the board. I think that wraps up the summary that I prepared for the bill, and I think we had some amendments that we can go through, but I'm happy to address questions if need to.
And first, I want to say that we have a lot of good assisted living facilities in our state. But as always, it seems that the bad guys come along and they put a spoiler in for the good people. And unfortunately, here at the legislature, we cannot write a bill that just goes after the bad guys. So we have tried to delicately balance this one, recognizing that we have lots of good providers and that we've heard from them, and we don't want to put them out of business, but that we also have to start setting standards and leading the way for our state to become a leader in elder care. Y'all have helped me pass, for the last 4 or 5 years, bill after bill going after the bad guys that endanger our seniors. And we'll continue, I'm sure, to work on issues. But we're making great strides, and hopefully Georgia is not going to be at the barrel of the bottom of the barrel, but we'll be more of a leader on trying to realize that we're an aging society. People in assisted living, their average age is 84 years of age. When you turn 85, you've got a 1 in 2 chance of having a full case of Alzheimer's. So we are dealing with sicker and more fragile as far as their cognitive thinking and also their physical well-being. And I think this bill goes a long way to start meeting those needs.
Thank you.
And that's what we're trying to do, and we'll be glad to answer questions.
You do have a few questions, probably. We'll start with Chairman Petrie.
Thank you, Chairman, and thank you, Chairman Cooper, for, I want to make everyone aware, I co-sponsored this bill, and I appreciate all of your efforts to address this very serious issue, something obviously I understand this industry well, and as a chair of aging, very important to me. I want to make a comment, and then I want to ask some questions of the department, and I want to make sure the department knows these are friendly comments, but I feel like I have to say this, okay? And what I'm going to say is this. We can pass rules and regulations. We can pass new statutes to regulate an industry. As Chair Lady Cooper said, overwhelmingly, our providers in this state are good providers who are dedicated to this population. And I'll remind everybody here that we have in the United States 100,000 deaths from hospital-related errors a year in this country. So I don't care if it's a hospital, a nursing facility, or whatever. We have issues, right? But I have to say one thing to the department. I believe that right now, no matter what we do to improve the rules and regs, which this bill absolutely will do, none of it matters if we don't have facilities adequately surveyed. And I believe that we have work to do to ensure that the department has the manpower and the quality staff to hire and retain the nurses necessary and the surveyors necessary to adequately enforce these rules. We can pass rules all day long, and if it's another rule that doesn't get surveyed, it's meaningless. And so I have to say, we're doing our part, but I will do my best as a member of Health Appropriations to see that we also recognize that we need more funding for the department in terms of HFRD to survey these rules and regs, because every good quality provider, and that is the overwhelming majority, wants to be thoroughly and fairly regulated so that the bad guys that Chair Lady Cooper alluded to are winnowed out. We need that, and I say that to my friend who I have tremendous respect for, Mr. Hood. Tremendous respect for you, sir, but I believe that this needs to be said. Having said that, I have a few questions. And just to confirm, and again, I co-sponsored this bill, I very much appreciate Chair Lady Cooper working with us to make sure that we contemplate the needs of the industry and, most importantly, the needs of consumers. But I did have a quick question. I want to just confirm a couple of things. I want to come back and ask you to explain why let me do this. You're going to amend Section 2. Let's wait till you do that on the amendment. I want to ask then,
Reverend Petrie, it's going to be removed totally.
Okay, thank you. Got you. On line in Section 3, all facilities, regardless of size, will now be subject to these changes in fees. Is that correct, Chair Lady? Okay.
Yes, sir.
So if it's a 2-bed personal care home or a 500-bed assisted living community, they will have the same fines. Is that correct, Mr. Hood?
Right. I mean, I
Thank you.
questioned it when it came up, but it's in the law.
That's okay.
And this includes hospitals, if you want
Yes,
to know. I mean, it's
right.
across the board.
Okay, thank you. And I want to emphasize on, to my point, I want to emphasize something on line 101. What Mr. Hood.
I'm sorry, can I clarify?
Yes, sir, please.
So the new mandatory fine of $5,000 is only applicable to long-term care entities. So that's personal care homes, assisted living, and intermediate care, and nursing homes if it's a state fine.
Gotcha. Okay. Gotcha. All right. On line 101, we're codifying the recent rule change on transparency, which I support and think is a great idea. But I do want to recognize, in light of my previous comment, that this is an item that was supposed to be done by the department. And now what we've done, to emphasize my point for everybody in this room, we've now put it in law, in statute, that providers have to do this when the department was supposed to be doing it. And so when we add burdens on the private sector that could have been done by the department, we have to understand, I support this measure. I think they should be doing it, and I'm all in. But I think, again, we need to make sure the department has the resources to do issues we had already decided long ago they should be doing. Okay, now to get to a question here. On memory care units less than 25 beds, Mr. Hood, they will be subject to the same 1-to-12 staffing ratio, and I just want to make sure everyone here is aware of that. Same staffing ratio in all memory care, regardless of whether it's a personal care home or a personal care home further licensed as an ALC. Is that correct?
That's correct. So we have a certificate program carved out specifically for memory care.
Gotcha. Mr. Chairman, I think that's most of the things I wanted to emphasize.
Thank you, Chairman Petrie, for your
Thank you,
work
Mr.
on
Hood
this
and
as
Chair
well.
Lady.
Okay, just a quick follow-up on that line 85, the injury and the $5,000 fine. Is that, that is for injuries, not illnesses, but an injury could include a bed sore or pressure ulcer, couldn't it?
It says serious physical injury in the definition, so I certainly think that would be potentially a bed sore, depending upon
If it caused a loss of
the
life
grab- right.
eventually.
Right.
Thank you. Chairman Barr.
Thank you, sir. Thank you all so much for your work on this, and I apologize to members of the committee. This is not my wheelhouse, so is it possible that you could explain the difference between certificate and license?
Sure. So specifically, you would have to have a license to operate, let's just say, an assisted living community. So there's parameters already in statute and administrative rule for an assisted living facility so it has to be 25 or more residents. It has to be a healthcare facility, which has different fire code standards for mobility and accessibility. That is already in statute. So rather than, we don't anticipate, or we're asking to only authorize those facilities who already have a license to operate an assisted living or a personal care home to be considered for a certificate. So it's like something that we would add to that licensure if they meet this additional criteria.
Okay, very good. Thank you. And may I have a follow-up, sir, Chairman?
Sure.
Somebody who has had the experience of grandparents in some of these facilities and have taken care of grandparents outside of these facilities, the notification process that you talked about, would that be to loved ones as well, or would that only be directed to those folks? How would that notification process be interpreted in your opinion?
So there's an administrative rule that goes into further detail for notification, but in general, it means that there's a posting at the facility, so anyone visiting the facility can see what the violations and plan of correction is, and then if the facility maintains a website per the administrative rule, that it be prominently posted on their website as well. So those would be, it's meant to be at the public at large, so if you're considering or if you're a resident.
Very good. And one last, if it's not too much. Okay. On line 76 and 77, traditionally, when we impose things like this, we usually have a shall or a may. And I'm just wondering, maybe legal counsel could help us out with that. It has to do with the fines.
Yeah, that's that excerpt starting on 76 is basically giving the department the authority to do that. So it's not a shall there, it's authorizing them to do that. So it's in their discretion.
Very good. Thank you. Thank you, sir. Appreciate that.
Representative Hutchinson.
Thank you, Chairman. I have a question. As I understand it, in Section 9, this is codifying what you already have in policy. Is that right?
You're talking to the memory,
Mm-hmm.
the memory care. This is
Yes,
more specific.
administrative.
This is more specific than what we
It's
have
more
in policy. Most of the training requirements that are referenced here do come from our administrative rules, where we're regulating memory care centers where they exist today under these licensure types.
So I guess my question would be, how is this different? So are we asking for 50 more classes versus 5 that they have now? How much more regulation are we looking at with this?
So specifically, I think what we're talking about is particularly the staffing ratio of 1 to 12 is not in the administrative rule process today.
Okay.
It is, as I talked about, it's surveyed more on the process of what are the patient needs. But this gives a guardrail of that 1 to 12 at all times. I think that is the biggest part of that. And then it's statutorily requiring the training, which is much more authoritative than our administrative rules. And lastly, what it does is it means that they have to apply for a certificate and go through a survey process and review process to obtain that and show that they meet each of these criteria, rather than just us going out and using an administrative rule for a violation after the fact. So they have to preemptively apply and show that they meet the criteria, presumably before they begin care. Although the way this is structured, it's a year that we have on the effective date in order to allow the department and the facilities to come into compliance and complete that process.
So this is similar to group homes where they have a lot of these requirements already in place, they have surveys and such. Yes.
I think of group homes as smaller than this. So
Okay.
when I think about this, to me, it's, and maybe Representative Hood, it's a large facility similar to a nursing home. It's just different levels of care.
Okay.
Whereas I
just-
think of a group home as a smaller type.
Well, I guess if this This seems like it should have been happening a long time ago. I'm surprised that we're just now in 2020 putting this into. And I have another follow-up. Go ahead, Chair. Lady Hicks.
I think we had such a hard time even getting the assisted living designation. God love the nursing homes for what they do, but they really didn't want this intermediate step. They wanted people that just had a little bit of cognitive problems to have to come and live in the nursing home. And lots of us thought that was terrible, that, you know, they should be able to live their life out with a little bit more help, but not in a nursing home where people had much greater physical needs and need skilled nursing care on a bigger basis. And it took us a long time to get it. And it was just as there was really an uptake in elderly people. And I think the idea is that everybody that moved to an assisted living facility was going to do so when they were, 67, 68, get rid of the grass cutting. And I guess we didn't think that they'd be living until their 80s and the higher levels. And I think that wasn't thought through that even if they came when they were 67, but if they stayed till they were 84 or 90, that they would have different levels that they needed in care. And so I think that's why these problems have arisen. And to Representative Petrie's comments about it, and he's right. I'm a nurse. I believe in preventive medicine, and I am sure he does too, even though he's not a nurse. John is, which has been very helpful. But so I try to prevent accidents, or I try to, prevent illnesses. And so I'm hoping by being proactive on the front end that we will have less problems for the department on the back end to react to. Now, that may be pipe dreams, but I think one of the biggest places that it's going to be helped is in the memory care unit. Those are the people who need the greatest amount of supervision. And it's not easy dealing with somebody that has dementia and maybe has hallucinations, or the night syndrome where they wander all night long and go into other people's rooms and want to go through things. That's not easy, and it takes extra training. And so by doing this separate certification and really honing in there, I think that will help make a major step.
And I also had just one more follow-up question. As a mandated reporter, I've been hearing from a lot of my colleagues who are concerned that they don't have the protections that they need.
Okay, it's one of the amendments that we have. Okay. Now, I have a sister that's a lawyer, but I tend not to like lawyers. And your colleague was nice enough to share her information with me. But it sort of gave the people an extra right to sue. I don't know what it's called legally, but it sort of elevated it. And so what we do is we have an amendment that we want to put in that goes, and it's sort of like we have it in other areas for nursing homes and all, where there are rules against retaliation, but it doesn't go as far as starting right off the bat about that, you have this right of, come on, a lawyer, help, and we have a lawyer, and the right of, the right to sue.
Cause of action.
Okay, so anyway, so we will be adding an amendment that will cover that. And it's not quite as specific, it doesn't outline every single thing, but it is what we have for the nursing homes already, and it does tell the person who's going to have to report that you should not be retaliated against, and that there is something that you can do if you feel like that has happened.
Thank you.
Thank
Chairman
you.
Jaspers.
Thank you, Chairman. Chairman Cooper, your skill at bringing people together and solving an issue has really been put to test, and you have came through like a star. Because I know for years, your passion for elder abuse. You shared that with me many years ago. Now, my question, just as like Chairman Barr said, maybe something I just don't understand, but look on line 293 and then like 312. I found it on the same page in a couple of places. As we're talking about nursing services provided by a registered professional nurse or a licensed practical nurse, and I know many times in this committee we've talked about the differences in their abilities and skill, and there's a big difference in those two. And I just was curious from the department what their thoughts are on that, or
Well, part of it is realization of our nursing shortage. The fact that in some places you might not be able to find an RN. But the other part there is education in here on requiring both the RN and LPN to have education toward evaluating and working with these patients. It's something that even the RNs don't get nowadays. That kind of an in-depth thing. So we do put that in so that they will have extra training to do assessments. But lots of the RNs now would rather be walking behind the desk with a computer than they would out checking on patients. And very often, it is our licensed practical nurses that are much more adept at checking a patient, turning them over, and seeing how that decubitus ulcer is doing, and whether it's just beginning and they can take care of it, or it's time for that person to go to the hospital. So part of it is because of recognition of the lack of availability of certain kinds of staff across our state, and the other is that we're going to rely on some training for them too.
thank you, ma'am.
Okay, John?
I'll also speak to that. Good question. I just wanted to bring to everybody's attention that currently there's no licensed nurse whatsoever required. So we're adding nursing hours, every week, a tiered number of hours based on the number of residents being served. And we're also limiting the nursing service to a very light or limited nature.
In other words, they're not going to be passing out prepackaged medicines or doing charting or things help in the front office. They're there to assess and work with patients and other staff members on good care of patients.
And the assisted living model is a non-institutional model. If a person needs continuous medical care, that's when they would be moved to a skilled nursing home. Providers of assisted living and consumers are seeking a non-institutional setting where they can age in place, get care that they need when they need it, without being forced into an institution. And also I want to point out that these are private pay residents. They are choosing where to spend their dollars, and it's a relationship between the provider and the consumer. And the provider needs to know the credential of the staff in the building. They need to know what the requirements are, and they need to know what the scope of expertise is before they make their decision. But once that decision is made, there's always a risk-reward balance, and that's what we've tried to do. And I applaud Chairman Cooper and the department for working with me on this to try to find some harmony between the risk and reward here to both consumers and providers.
Thank you. A couple more questions, 3 more. Representative Gordon.
Thank you, Mr. Chair. And Madam Chair, thank you so much for the work on this bill, along with the department. Actually, I think most of my questions were answered. 2 of them came from Chairman Petrie, and I appreciate him bringing those issues up. I guess the third and last was, and I apologize for coming in, I think probably, a couple of minutes into the presentation of the bill, but I was just curious as we talk about assisted living and personal care homes, and I know there's some verbiage that kind of classifies the bed count as 25 or more, and some of that was cleared up again with Chairman Petrie's question, but I was just curious to some of the smaller personal care homes, 1 to 3 beds, from the fine perspective, are they fined at the same level as some of the larger ones? Because I've been in some personal care homes that only have 2 or 3 beds, one person, owns, lives, and takes care of the residents, and I was just curious to, I guess from an economic standpoint, are they going to be expected to keep up with those same fines as a personal care home that may have 100 beds or 25 beds?
So the fine structure, I'll remind you, is really not based upon the size of the facility. It's based upon addressing the resident's care.
Sure.
So the matrix that is there is designed across the board for all facility types, regardless of how big that facility is. So they're going to be fined the same if they, so if it's an egregious in a small personal care home, if it's egregious and a death has occurred, they're going to be eligible for that $5,000 fine if you can show cause.
Representative Sharper.
Okay, thank you, Chairman. Section 5 right here, line 153. It says about ensuring that each direct care staff person receives initial and annual training coverage topics specified by the department. Since a lot of what I'm seeing here is really upbeating and getting people trained, or if the department is gonna basically come up with some curriculum, is it gonna be more like something they can do online, or is it gonna be a training that people can go to, things like that? Because I'm wondering if they're going to keep up with it on a local, at one, like maybe one of your facilities, where the training is there, or if it's online, that is kept in that file for the personnel file, and would also be giving to the department to have on file as well. But I'm really trying, and also, will your facilities pay for the training for the faculty, the training to go, or, and why they're taking the training? But talk to me about that.
Thanks for your question, Representative Sharper. As a provider of assisted living services, we do cover the cost of the training, and there are providers do it differently. Some do training in person. Sometimes there's online training material. But I believe what this bill accomplishes is it requires a demonstration of competency. And so no matter where the training takes place, that employee has to demonstrate competency to be sure that what was presented to them is actually learned and can be applied.
Administrative rules or making rules.
Did we answer? Does that answer your question?
Well, kind of not really, but if the department is gonna be specific in what they want the people that are gonna get the certificates to have, then I just want to make sure that they're aware of the training and that it's being done and confirmed, not just any kind of, or you may say you can have training from other facilities or other companies that we approve of.
Right.
Okay,
So
but I'm just making sure.
There has been a lot of discussion on a portable training that's portable.
Okay.
Say if a caregiver is working at one employer and they leave there and come work for another employer, as long as that employee can show evidence that they've received training, it's portable. And there's discussions ongoing about other ways to standardize training and ensure that there's recognizable ways to ensure that training that's been done is recognized when they come and apply for a job.
Right, because just a little helpful hint that if you guys do it, the portable training and everything, that if the department also has copies, and the workload may be too big for that, but if they have a copy of that, so that when a person does go to another job or something, at least if they've lost everything or company went out of business, they're no longer in business, someone will have it on record, and that won't put the employee at a bind either.
Thank you.
So
And
that's just a thought.
this will be done by rule,
Right.
just like we do other
Okay.
rules and choices. And we are setting up a board to help
Okay.
where everybody can have, the input on. But I want to make one thing, and the paper didn't, I don't think they picked this up anywhere. I started last year, we have a wonderful system here under the HOPE. It's called the HOPE Grant. And where we have jobs that we have great deficiencies in the number of people to fill them. I know welding used to be one, and that you could go to one of our technical schools And through the Hope Grant program, you didn't have to pay tuition, and you could become a welder. And many young people have done that. And for years I've been hearing, there's not enough workforce, there's not enough workforce. And over, I guess, almost a year now, time flies when you're having fun, I have been asking the governor's office if they would add certified nursing assistants to that list, which the nursing homes and Jesse and, Representative Petrie and LaHood have said that would be a great advantage. Well, as of 2020, the governor heard the need, and certified nursing assistants, people who want to become certified nursing assistants, can go to our technical school, and through the grant program, if they're eligible, through the grant program, and that means I think that they're a citizen and live in the state of Georgia and that kind of thing, they can go and their tuition will be paid. And as I've traveled around the state, down in the Americas area, that president of that technical school says they buy the books for their students and then they take them up again. And so they don't have any problem with even helping people who want to be with their books. So this is a big plus, and I cannot applaud the governor enough for hearing the plea for help and the plea for need. So could you please let people in your districts know about that? Because typically, we don't have any way of getting that information out, and that's now available. So,
Chairman Petrie, did you?
Thank you, Chairman. Again, and I have a question for the department, but first I want to say to Representative Sharper, very good point, because portability is huge. Chair Lady Cooper was just speaking to the issue of CNAs. Folks, we have a crisis. There aren't enough caregivers. And that's, we have to contemplate all of that as we think about these rules. So these training requirements, if they have them wherever they get. Listen, there's 45% turnover rate in this industry. 45% turnover rate. So yes, portability, huge issue, and well-made point, sir. Quick question for the department. Just want to confirm on the administrator, because I'm looking at a new sub. I want to make sure I'm hearing this right. Only 25 beds and over would have to have a certified administrator in those facilities, not the smaller facilities that Representative Gordon was speaking to in terms of having a licensed administrator, correct?
that's right. I mean, I think they would do well that anybody that's running any of these kind of facilities had them, if you
Sure.
want to know the truth. But I'm a pretty strong person, but this is what I'm taking on one area at a time.
Yeah, but
So-
they're mom and pops, and they're serving a lot of very poor.
Right.
The poor of our society are not in assisted living communities. So that's wanted to confirm that. One other thing, in order to certify people that you hire in an industry where, in a world where everybody's working and there is no, our unemployment is historic lows, you have to have time to train somebody on the job. Are we going to have the ability to hire a person to be an administrator and have the time to train them without being penalized during that training period? That is my question for Mr. Hood.
Well, it's in the
Or the
bill. It
chairman.
says 60 days.
60 days, okay, I wasn't seeing that. Thank you. That was my question.
Chairman Barr.
I think this may be to Representative LaHood, maybe a practical aspect of starting on line 312. And I'm not sure how to delicately put this, but if I have, I guess, are there communities that have 1 to 5 people? And then to follow up on that, with a minimum of 8 hours per week for a nurse, I'm concerned about the financial burden of 1 to 5 residents incurring the cost of that. Can you help me get comfortable with that as far as financially? Obviously, that's going to go onto those folks. Can you help me understand that a little better?
Tell me where you're seeing 1 to 5.
So it's on line 313, for assisted living communities with 1 to 30 residents, a minimum of 8 hours per week for a registered professional nurse or a licensed practical nurse.
Yeah, understand your question. but kind of stepping back and taking a broader look at the bill, this provision only applies to communities with 25 or more beds. So this would never apply to a community with less than 25 beds.
So read
Oh,
line
I'm sorry.
three-
This is memory care.
313 for me.
Okay, memory care, it could. You're right. So, but yeah, I mean, you make a great point, and that's why I'm so grateful for Chairman Cooper and the department for letting me weigh in on some practical, just some practical variances and factors that weigh in here, because this will absolutely have to be passed on to the consumer. And if we price this too high, I mean, the consumer has a limit. And I chaired a study committee over the summer and fall about how to find innovative ways for seniors to be cared for, because there's a lot in this state that will not be able to pay their own way. So we were mindful of that, and we tried to tread lightly to add some meaningful provisions without pricing consumers out of the market.
I mean, Representative Barr, we can't make this bill work with no consequences. It's like every other bill. These tend to be bigger, and we appreciate those mom and pops that do the smaller one, but you have to set standards. And, so they'll have to adjust and become bigger, if that makes it more financially feasible, because they will need to be able to do that. But if you're going to run a memory care site, you need a nurse to evaluate people, or somebody that's trained, not just somebody who decides that they think they'll open it up from the bottom of their hearts and because they care about people. So.
Thank you.
Representative Howard.
Thank you, Mr. Chairman. My question may not be relative to what we're doing here, because I think we're doing a great job in with assisted living, personal care. But there are some hospitals, specialty hospitals, that are out there that have equal amount of bedding for patients that have to have long-term care. And are there any, is there any requirements in here that would deal with hospitals? Because I'm speaking from personal experience here. Some of there may be specialty hospitals that have more CNAs and less nurses working in there. Therefore, treatment for those patients does not equal what it should be. If that makes sense, I'm speaking I'm speaking from experience from a small specialty hospital. I know this bill probably don't go into that area, but there are some problems in that area.
So this bill is primarily specific to assisted living licensure and personal care home licensure and to the certificate. The only part that potentially, to my understanding, would touch it would be the fine structure, where we're doubling fines up to $40,000 across facility types if it was applicable on a state fine to that particular facility. But as far as staffing ratios, that's addressed elsewhere for
maybe
hospitals.
that's something for another day.
Yes, sir.
That we need to take a look at.
Chairman Hogan.
Thank you, Mr. Chairman. Compliance. How's the department equipped to make sure compliance to the stuff we pass up here, and doing reviews and surveys of these facilities to make sure that they're doing what they're supposed to do?
So I'll answer that this way, Representative. We've met the interval for doing surveys of state licensure and investigating complaints that have come forward, and we'll continue to do that with the existing staffing that we have allocated.
I think Representative Petrie addressed some of that, but we can pass all the laws we want to, but we've got to beef up the department's ability to go out and do investigations.
I think if you know me very well, you know I just as soon take on a department as anybody else. So I'm not taking up for them. But I will tell you that even if they did a survey every 6 months, that's not going to keep the bad guys from doing something in between. There has to be a standard. And I guess what, and one of the reasons I'm so glad the paper did the articles, families now know what goes on in these places. It's been put out there in very shocking ways. And if families and people in these communities don't get the idea that they need to be the eyes and ears of these fragile patients, nothing is ever going to make a difference. And I would think that the families will become aware of, and they're watching. I've never seen so many comments and responses to this from all over our state to those articles. And so I think that they will know staffing ratios. They will know what's been put into place more than they have on a lot of other bills. And I think they will be our eyes and ears to see whether a great deal of this gets put into place and is followed. But I don't think we can hire ever enough inspectors that we're going to catch everything. I'm just hoping, I told John to save his money, and it goes for Jesse too, because I'm hoping some of the bad guys will just flat get out of the business. And I told him to save his money so he could go buy some of them up nearby him and run them in the right way. So, you know, if any of the rest of you want to run one in the right way, hopefully some of the bad guys will just get out of town and, you know, quit putting our senior citizens at great physical and emotional harm.
Thank you. I think it's been robust committee discussion. You did mention, Chairman, that you had some, I know part of the perfectioning process, you had some amendments. Would you like to discuss them, even though we're not to that point?
Several.
Several.
Okay. and
Please
then
proceed
we'll
however
just-
you'd
we'll
like.
discuss them all, and can you just, we'll say that this is going to be one big amendment. Betsy, I think you better get front and center. Here again, this is in response, trying to listen to everybody, trying to, you know, try to get this as good as we can get it to get, but we've got to get it moving on. Okay. First one. You ready? I mean, whatever you want to do first, or go
Maybe the
through.
first one that I have right in front of me is the part that we talked about retaliation, and I can give this to Betsy, but it says to add to 30-5-4.1, no person shall discriminate or retaliate in any manner against any person who makes a report pursuant to this chapter, who testifies in a judicial proceeding arising from the report, who provides protective services, who participates in an investigation, or who participates on an adult abuse, neglect, and exploitation multidisciplinary team under the provisions of this chapter, or any disabled adult or elder person who is the subject of a report. So that's to address the retaliation that the chairwoman spoke of earlier that we wanted to add.
Right. Thank you. Now we get it. So that would be one part of the big amendment. And I hate that we have to do this, but we are running out of time, and trying to find a room for us to meet is getting pretty impossible. Okay, you're next.
The next one is to strike section 2. I referenced that earlier. Unfortunately, for the expedition of a waiver that's referenced in section 2 of the bill is in conflict with the administrative procedures method of how we process waivers at the department, which requires transparency and a posting of 15 days. Therefore, we don't think that's practical, and we need to remove section 2.
So just section 2 goes out completely.
All right.
All right, next part.
The next part that I have is on lines 111, 279, and 369. We would like to add the word facility in front of volunteer.
That is to make clear that there was some question about who would be responsible if it was a volunteer. And it's if it's a facility volunteer, somebody that they get to come in and do music lessons every week, but they don't get paid, then they would be responsible for them, and it's just a clarification, not somebody that's just coming in to say hello. Is that right, John?
Or at the family's discretion.
At the family's discretion.
I do have a question. Chairman
Got a question?
Barr.
Sorry, can you go over those lines just one more time so I can write them down?
Sure. 111, 279, and 369.
Thank you.
It's the same language in each place with that volunteer.
Very good.
Okay.
So it's facility volunteer?
Facility volunteer, just for clarification. Okay. Where do you got mine? Okay, where were we gonna do that? Remove the,
I think we're on the board. The next
Okay.
one I have is the board.
the board,
The department, there's a proposal that the department have a representative on the administrators board. We don't presently have a representation on the nursing board administrators, and the reason for that is, to my understanding, is because we believe that would potentially create a conflict since we're regulating those nursing home administrators, and we also would be regulating assisted living administrators and personal care home administrators. So we'd like to strike that, and there was a provision brought forward to add, I believe, a person who has
a minimum of a bachelor's degree and specializes in elder care.
in replace of that.
In replace of
In
that.
replace of the one that was there for the Department of Health Facility Regulation Division.
I mean, that actually could be a physician who is that specializes in treating the elderly, or it could be a social worker who's gone on to do one, or it could be a nurse practitioner who has a specialty. You, as a nurse practitioner now, can get a specialty in elder care. So it sort of opens it up and puts that person on the board. But they will not be, they can't work for one of the nursing facilities. They have to be an independent person. So that would be one. Okay, also on line 116, I'm sorry.
I think we need to talk about that one in a minute.
Okay.
So on line 116, it's any other limited nursing services. That's in the personal care home provision. And as we were reviewing that prior to the meeting, that's because we still have nursing services in the memory care. And if you have a personal care home that is going to get a memory care certificate, we would need an authorization for nursing services. Now, if we think that's too general, perhaps we would add a statement after it to say when a memory care certificate is issued to make it tighter. But that was the reason I believe that we had any other limited nursing services in the personal care home.
Okay.
This is really, is there any problem with us limiting it to the personal care? This is really, okay. Jesse?
Chairman Petrie. Yes, just want to make sure from the department, none of this would encumber in any way the ability to use proxy caregivers in any facility.
No, sir.
Just want to make sure.
It's just permissive on CMA, so yes, sir.
We were trying to give you something, Representative Petrie, that if you have a memory care unit and you want, since they require a certified medication specialist, that if you want to use them in the rest of your facility rather than proxy caregivers, you can do that, to give you something. Okay, what else?
That's all I have.
That's all we have. If we,
So Betsy got those, right? And she'll read them back to us at the appropriate time. Would you like to hear public testimony now? Let's go right ahead. We do want to try to keep this as brief as you can.
about a minute, because we're
Keep it
running out
down
of
to
time.
about a minute, if you will. I appreciate people's patience, but this is a crucial issue, and a lot of work's gone into this that we appreciate. Please, Ms. Boatwright Quinn, just introduce yourself, if you will, and then briefly tell us your support or opposition.
Sure. Good afternoon, Chairwoman Cooper and members of the committee. I'm Mary Lee Boatwright Quinn. I'm the Director of Government Affairs for the Alzheimer's Association Georgia chapter. I want to commend Chairwoman Cooper for her work and her leadership on this bill. I'm here in support of HB 987, and just to bring forth a few minor suggestions of changes that establish strong dementia training guidelines. In the 2017 publication of Dementia Care Practice Recommendations, the single most important determinant of quality dementia care across all care settings is direct care staff. Direct care providers are the hands-on workers in assisted living environments, described in the practice recommendations as nurses, nursing assistants, nurse aides, medication aides, and personal care aides. The direct care providers collaborate with other staff who are important to the lives of the individuals with dementia, and those include dietary, housekeeping, activities, etc. It is essential to ensuring quality care in these settings that all of these folks have training. We have some suggestions for, with relation to the department setting up the base of the training. It is our recommendation that the code language ensure that training is evidence-based, competency-based, which means they demonstrate the skill post-training,
Right.
And have a minimum content requirement. We recommend that the department establish a recognized course or a minimum standard that follows perhaps the GARD competency guide for dementia care that was published about 1.5 years ago.
Okay, can we,
And then
this will go through rules and regulations, and that is where you would have the opportunity. This
To
is
add
not the
those.
time to do that, and we are on a time limit.
Okay, and the last thing is just in the recommendation that we would like to see the addition of someone appointed to the State Board of Long-Term Care Facility Administrators that has knowledge, and expertise in dementia care. We believe that voice
That
is
we're
important.
making that, we're in the field of elder care.
Yes, I would include specifically dementia care, if you wouldn't mind.
Go
And-
tell Joe right now to
Okay.
put dementia care right there, and
Awesome.
we talked about it, so thank you.
Okay, and thank you so much for your work on this and
Thank
for the opportunity to show our support.
Okay, who's next? Vicki Johnson. We're gonna do yours, we're gonna have another meeting. What? Okay.
My name is Vicki Johnson. I'm the chair of the Georgia Council on Aging, and I want to commend Madam Chair and all of you who have been working on this bill. We have been pushing advocacy for this for over 2 years with the Georgia Council on Aging and co-age members, and we commend this modification. One statement that we have is that everyone wins when the consumers are protected and the assisted living industry is vibrant in Georgia.
Beth Cadence.
I'm Beth Casey, and I'm going to testify on behalf of the Georgia Senior Living Association, but also I am a core dementia trainer for the state of Florida, so I'm going to make a few comments and congratulate you on what you've done so far with this bill. We're very appreciative, and as representing senior communities across the state that have thousands of positive outcomes, we applaud the standard that you're bringing for us. We want to raise the bar of accountability across the board for all members, but we know it's a delicate balance to seek providing safe, quality care with a price that's affordable to our citizens. The one comment we want to make is on the educational side. What is in the bill, if you look at on line 408, is there's 4 hours required for the staff to have dementia-specific orientation within 7 days, as you've alluded to, working in the center. I won't allude what
I
those
think
are.
Beth, if you let me interrupt, I think we've taken care of that. What it says is they have to have it before the 20 hours, before they can work independently. That means that they can work, but they just can't be there by themselves until they've had the 20 hours.
Until they had the 20 hours.
Right, yes, ma'am, and it's in the bill. And what Beth was concerned about is that we said there had to be, 4 hours before they could even, go and work, and 16 more hours of training. And, they felt like that would be an imposition, that they wanted them to be able to work quicker than that. So we said before they can work independently, they have to be with somebody who's trained and able to work. Does that answer the question?
Well, a little bit. I just want to elaborate because it is a very important point. As instructing CNAs for a long period of time, the importance of training for memory retention employs a spaced repetition of training. which will overcome the data overload, which has a low proven results. That means putting someone in a classroom and educating them for 20 to 24 hours before you put them on the floor. If you take that in addition to the fact that each and every one of us has to precept with another care aide that particular individual, to learn the individual person-centered care of that individual, their wants and needs, it could be a week and a half before I have them on the floor. Now, I would say to you, if you sat in a classroom for a week, how much you would retain, rather if you had small retrievable bits where you could be re-questioned and tested over perhaps a 90-day period, there would be much better skill acquisition. So we are recommending that you would propose the specialized training in this bill occur over a period not to exceed 90 days. And additionally, we'd also like to add the requirement that at least one staff person, as you've said, be on duty while other employees are in the process of development become fully qualified. So they would not be working independently, as you said. But this is very important to us. Additionally, back to your comment on portability, we would like to challenge this new board that we do look at some portability certificates for dementia care to raise the standard so that if someone works 2 jobs, they're not going through the same orientation twice, but they have raised their skill level for the provision of care.
Okay.
Again, we thank you and we appreciate all the hard work on this bill.
Fine, thank you. Representative Hutchinson.
I had a question for, thank you, Mr. Chair. I think I am concerned, and I've heard from some of our committee members, although we like this bill and we want to see it passed, is this going to put small businesses, the small businesses, out of business?
There is a cost to this. I mean, I won't mislead you. There's a cost, but I think that there has been a delicate balance in working on this bill that it's a cost we have to take on. And if there's ways that we can do the portability certificate, which will reduce the cost of training where you can share it between facilities, that will help. And I think that's an excellent question.
Beth, as we talked about the other night, when you were one of the people that we talked to and that we listened to, you know, many of these things will be done by regulation. And the training course that you talked about in Florida, I made a specific request that when they look at the rules in the board, that be presented to the board, that we do that kind of training. So we did listen to you.
Oh, well, we
but we
appreciate
think
that.
we've made it flexible enough that it will fit. And when you can get people to the floor for part of that experience after 4 hours. It's just not independently. They have to be with somebody. So that flexibility. Jenny Helms.
Madam Chair, members of the committee, I'm Jenny Helms, president of Leading Age Georgia. We're the association that represents the not-for-profits and other mission-driven providers of housing and services for older adults. And we greatly appreciate all of your work on this bill. And like you, I served on the AJC committee, the viewing at the GPB, because I believe in a quality improvement approach to improving care and assisted living. It's needed. And so this bill comes a long way. And one of the other states that's doing a lot of great work in this area is Oregon, and they focus on a quality improvement approach. And one of the things is recognizing that behaviors are part of the problem with dementia. And that one of the doctors here in town said that 60% of all of the behavior challenges you see are based on untreated pain. So I would like to see the education piece add one, know how to address pain like they have in Oregon, and to make sure it's portable. The CEO of Wesley Woods said they hire for experience, and most of them would come with a certificate, and we want to make sure that that is available. And finally, in other states like Oregon, their equivalent of DCH has quality improvement initiatives and would put the top finds training modules based on the top survey findings online so that organizations can go on and online and learn about what the surveys are showing. We work closely with DCH. They're fabulous with us. We have them do the top 10 survey findings, and that's really helped our members improve quality. But Georgia, in the nursing homes, we've had the Alliant Quality Improvement Initiatives, and they've really helped the quality of care. And I think that's the future, not so much fines. I understand the need for fines, but we really need to focus on quality improvement initiatives and work through the department to have that.
Okay, and I thank you very much because I appreciate all the work that you do. And it's not trying to make anybody short. It's just that this is the bill, and to get into the weeds of it like that, when it's something that the department can do and that we can do through administrative rules. And those meetings are open to the public. If you need for me to go with you to get help on moving some of these forwards, I will be glad to go with you to those meetings. I just got back from taking on the dental board because they were not instituting a bill like we had asked them to do so that we could let our dental hygienists do more cleanings and preventive medicine for our most needy children. You have my word, and I think people will tell you I will hold it. I will go with any of you to make sure that as we move forward, when we get this bill passed, that we can start making a difference in the ways that you are asking for in the rules and the regulations and the education that goes up.
Thank you.
We're taking sort of, not baby steps, but I would consider these are not toddler steps. How about 7 or 8 year old steps? And then we'll work on, getting them moving forward. Melanie McNeil.
Thank you, Madam Chairman, members of the committee. I'm the state long-term care ombudsman. We're advocates for people who live in long-term care facilities, personal care homes, assisted living, and nursing homes, and a few others. Thank you for everyone who is involved in bringing this bill forward. I really only want to talk about staffing feature of it. And what I can tell you is among the top complaints the ombudsman program gets is there isn't enough staff. And we get that complaint from residents. We get it from families. We get it from other staff who say they just don't have enough staffing. So I appreciate the staffing levels that are in the bill. I ask your favorable consideration for all of the features of the bill. Thanks.
That's everybody. Is there anybody else that did not get a chance to testify? We're just running up, and just because we're running up against the clock and we're going to have to put one bill off. And I think it's very important to nursing homes too. It's about in private rooms being able to put cameras to watch loved ones, and we're going to have to find a time to have that. If I can watch my dog in doggy daycare today and go on my computer and see what my corgi is doing, I think patients have a right, and their families, if they pay it, not responsible for it and all, and we will work with Representative Demetrius to work on that bill. Okay, who's this? Representative Hatchett.
So is that all the public comment, Madam Chair?
Yes, ma'am. Yes, sir.
At the appropriate time.
It's now.
I would like to make a motion to pass LC 338301S.
Okay. As it will be amended in the
Well, yeah, I know
okay,
there's
Chairman Newman.
amendments now. So.
That's a second.
Okay, we have a do pass and a second. Are we ready? Betsy, can you read the amendments?
Sure. Okay, so the first one's going to be the non-retaliation amendment that Joe read. Y'all need that read again, or do you get it?
Anybody need it read again?
What line is it inserted?
It's going to be actually a new section 1. We're going to slide that in and renumber everything past that because it's in Title 30, which is everything else in the bill.
It'll be a new section 1, and then they'll renumber everything. Did everybody get that? They'll just put it in as it was read.
And on all these changes, we'll have to reflect the changes in the title of the bill, so I'm not going to go through that.
Right.
All right, so that would be the first one. The second one will be to eliminate the current section 2 that starts on line 54.
So we're eliminating the current section 2 because of laws and things that we already have in place. The department cannot do that.
Okay, then the next one is going to be on okay, page 4.
Page 4.
Yeah, page 4 on line 111. In front of the word volunteer, we're going to add the word facility. And we're going to, that same definition throughout, so we're going to add that 3 more times, so 2 more times on line 279 and line 369.
279 and 369, and the one she just read, they will add the word facility. Volunteer. It'll be facility volunteer.
Yeah, also on that page on line 116.
On what?
Where we reference limited nursing services. We do have a definition for limited nursing services in another code section, so we're going to add a cross-reference to that.
Okay.
So at the end of that, we'll say, as defined in subsection B of code 2. And we're going to also duplicate that same change on line 264 and 370.
Okay, we will go to the code where there is a definition of limited nursing service and give the reflection back to the code. Okay, that's it.
The last thing, unless I missed something, is on the board, then we're going to replace,
This is about the board. And they replace the department with,
yeah, this will be on line 506 and 507, which now has the department representative. And so, and again, you need a little bit of discretion to decide this, but generally, say, be a new number 4 that would say one member who is a healthcare professional with at least a bachelor's degree, experience in elder care, and knowledge in dementia care. And then we're gonna add the caveat that shows that we're gonna do credits, actually starts on line 501. We'll say who are not personal care home administrators, assisted living community administrators, or nursing home administrators that perform pecuniarily interested in any personal care home, assisted living community, or nursing home, or have any connection with the personal care home, assisted living community, or
everybody got it? Okay. Is that it?
yeah.
Okay. You've heard the amendments. Thank goodness for Betsy. She does a great job for us all the time. I apologize to the committee for having this way, but we really have to get this bill moving. So what does the committee want to do about the amendments?
Move for approval.
I have a moval for an approval. Do I hear a second?
Second.
Did you have a question? Okay. All right. So is there anybody else, any discussion on the amendments? Anybody that got a question about the amendments? Okay. All right. Everybody in favor of the amendments as read by Betsy, say aye.
Aye.
Anyone opposed, no. Okay, the ayes have it. We are back to the main bill. So we have a due pass and a second on the substitute to House Bill 9087 as amended, and that will go out as a substitute is the way that the House does them. That's LC 338301S. Everyone in favor, say aye.
Aye.
Anyone opposed, no. The ayes have it, and I want to thank this committee for putting up with and listening to this, for your very good questions. We are going to either meet tomorrow, most likely Friday. If it's Friday, I know you want to go home, but we are going to have some last-minute bills, and if we wait until next Tuesday, that's putting people very close to crossover day. So we will move it really fast. There won't be anything this long. So when I get the time, will you make every effort to attend the meeting? If you have a bill or had a bill on this committee, you would want to show up and have people show up too. So as soon as I can nail down a room, I will let you know. And once again, thank you very much. We're adjourned.